Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Managing Neuropathic Pain and Paresthesia. My name is Gigi DeFibri, and I will be moderating this podcast. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download and via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Aaron Boster and Dr. Jacqueline Nicholas. Aaron Boster is a board-certified clinical neuroimmunologist specializing in multiple sclerosis. As a neuroimmunologist, Dr. Boster provides diagnosis and treatment of all types of MS, as well as a wide range of neuroimmunological conditions. These include neuromyelitis optica, neurosarcoidosis, central nervous system vasculitis, NMDA receptor encephalitis, transverse myelitis, optic neuritis, stiff person syndrome, and more. He also provides medical management of refractory severe spasticity with expertise in all treatment modalities, including intrathecal baclofen. Dr. Boster knew he wanted to become an MS specialist since he was 12 years old when his uncle was diagnosed with the disease. This personal connection and experience inspired him to treat MS patients and their families differently. His relentless focus on not just patients, but also their families, means they receive individualized and longitudinal care. He received his undergraduate degree from Oberlin College in Oberlin, Ohio, and his medical degree from the University of Cincinnati College of Medicine in Cincinnati, Ohio. Dr. Boster completed his internship and neurology residency through the University of Michigan in Ann Arbor, Michigan. He continued his training at Wayne State University in Detroit, Michigan, where he completed a fellowship focused on clinical neuroimmunology and multiple sclerosis. Dr. Boster is board certified by the American Board of Psychiatry and Neurology and is a member of the American Academy of Neurology. Dr. Nicholas is a board certified clinical neuroimmunologist specializing in multiple sclerosis and spasticity. As a neuroimmunologist, Dr. Nicholas provides diagnosis, treatment, and comprehensive care for all types of MS, as well as a wide range of other neuroimmunological conditions, like I mentioned earlier with Dr. Boster. She also manages intrathecal baclofen pumps and administers Botox for spasticity and migraine. Dr. Nicholas was inspired by patients she cared for with MS and NMO early in her training to enter the field of neuroimmunology. She is dedicated to providing personalized care to each patient and their family, taking the time to educate her patients on their disease and working with each patient to develop a treatment plan tailored to their own specific needs is her top priority. She strives to provide her patients with the best possible quality of life while helping them fight back against their disease. Dr. Nicholas believes that involving patients and their families in treatment decisions, respecting their beliefs, and educating them about what to expect results in the best health outcomes for her patients. Dr. Nicholas actively leads several clinical trials to help discover even more advanced treatments to help patients with MS and other neuroimmunological diseases. She received her undergraduate degree from Miami University in Oxford, Ohio, and her medical degree from the University of Toledo College of Medicine in Toledo, Ohio. Dr. Nicholas moved to Pittsburgh, Pennsylvania to train at the University of Pittsburgh Medical Center, where she completed an internship in internal medicine and a neurology residency, where she served as chief neurology resident. She continued her training at the Ohio State University Medical Center in Columbus, Ohio, where she completed a fellowship in clinical neuroimmunology, multiple sclerosis, and spasticity. Additionally, Dr. Nicholas completed her Master of Public Health degree at the Ohio State University College of Public Health to enhance the quality of her research studies to advance the state of care for her patients. She's board certified by the American Board of Psychiatry and Neurology. She's a member of the American Academy of Neurology, the Consortium of Multiple Sclerosis Centers, and the National Multiple Sclerosis Society. Welcome, and thank you both so much for joining us today.
Thank you.
Thanks for having us.
So just to begin, just as a kind of general introduction to what neuropathic pain and what paresthesia are, can you first define and kind of explain what neuropathic pain is, Dr. Nicholas?
Yes, so neuropathic pain is experienced differently by different patients. So when I see individuals in the clinic, they often describe this as a numbness that may be painful or a burning sensation. Sometimes it could feel just really sensitive if somebody touches their skin. This pain is caused by damage somewhere within the nervous system. So in the setting of diseases like transverse myelitis or NMO or MS, we see this quite commonly, and oftentimes this occurs due to the inflammatory lesions that occur in the brain or the spinal cord. And when these lesions interrupt the sensory pathways within the nervous system, they can often lead to unusual sensations in the body. Sometimes initially people will feel like they've lost sensation in an area, and then even as these nerves are recovering, because we actually have something in our nervous system called neuroplasticity, sometimes this will result in pain rather than numbness, so a sensation that somebody doesn't want to have. But the good news is there are lots of treatment options to help. So I'm sure we'll get into those as we move forward in the discussion tonight.
Great, thank you. And Dr. Boster, do you have anything to add to that?
Only to say that the normal sensory input when someone touches your skin involves all these elaborate wires that go from the skin up to the brain where that sensation is interpreted. And because of damage to the spinal cord of the brain from transverse myelitis or some other condition, those messages get scrambled. And so what the brain interprets isn't normal touch, it interprets something yucky. And I would also simply add that a lot of the neuropathic pain that people describe is very challenging to describe. And because we're not constructed to be able to read out sensory changes in the spinal cord very well. And when a patient is telling us in clinic, it's tough to describe, it kind of sort of feels like this, we know that we're dealing with neuropathic pain.
Great, thank you. I think that was both a really good kind of overview of what neuropathic pain is and how it potentially might manifest. So people also often hear the word paresthesia. Dr. Nicholas, do you mind talking a little bit about what that means specifically?
Yeah, so a paresthesia is a neurologic term that basically means an unusual sensation. So sometimes people will tell me that they feel, intermittently, maybe as they're going about their day, they may feel that they get sort of a painful sensation, or maybe not even a painful sensation, but I've heard before people say that they feel like there's water running down their leg and they look at their leg because they think something must be touching it and it's not. So it's any type of unusual sensation. And again, that's often the result of injury within the brain or spinal cord. Although we can see it in peripheral neuropathy as well, damage to the peripheral nerves.
Okay, thank you. And then, Dr. Boster, I know you talked a little bit about this, but a little more specifically, how or why do these neuroimmune disorders cause this sort of pain or these sensations?
So if you think about the way the nervous system is laid out, the spinal cord is kind of like the superhighway. So when someone steps on your foot, the information from the receptors in your foot go up the nerves to get to the spinal cord. And all that information goes right up the spinal cord to the appropriate area in the brain. And then the brain sends a message down the superhighway to your leg to tell you to pull it away from whatever's going on. So when you have a transverse myelitis, you're damaging the superhighway. And if you damage the back of the spinal cord or the side of the spinal cord, that's where a lot of these sensory highway lanes are found. And so it's very common that someone that has suffered a spinal cord injury may not just manifest a weakness or a difficulty with a bowel or a bladder, but they'll also have sensory deficits because of the way the superhighway is laid out.
Got it, thank you. And Dr. Nicholas, do you have anything to add to that?
No, I completely agree.
Okay, great. And then does, the pain that comes from, for example, TM or NMO ever go away, or, how might it change over time, Dr. Nicholas?
Sure. So oftentimes when somebody initially experiences damage in the spinal cord from transverse myelitis or neuromyelitis optica, it can be incredibly painful. That's one of the most common things that we see when somebody has an initial attack or even subsequent attacks. The key here is treating the inflammation as quickly as possible, because when that damage occurs and there's inflammation and swelling, it's really destroying those sensory pathways. And so getting care and seeing your neurologist to get this addressed as quickly as possible is important. Fortunately, we use treatments like steroids and sometimes plasmapheresis to calm down that inflammation, and oftentimes that can help quite a bit. Once the inflammation is calmed down, oftentimes we are still left with neuropathic pain, and there are lots of different treatments that we can use to try to manage that. And I think that that's just as important as how we treat the person's underlying disease or cause if we're able to discover it. So it's not just about preventing that next attack of NMO, but it's just as much about treating those symptoms. And so there are a wide array of medications that can be used. There are many non-medical therapies that we can use. And then another important factor that we can see after the damage that occurs from transverse myelitis or an NMO attack is that oftentimes as time goes from the attack, we can see the development of spasticity or severe muscle stiffness, and that's something that we do a lot in our clinic at OhioHealth, a lot of caring for that spasticity and that muscle stiffness. And so, the most common thing that I hear people tell me when they are cared for, somewhere else and they come in with their transverse myelitis or NMO, they say, they told me that this isn't painful and I shouldn't have pain. But, we actually see that that is incredibly common and one of the most common symptoms of this. In terms of the spasticity, again, there are lots of different modalities that we can use to treat it, but those either, having cramping or spasms or a leg that's jerking out or spasms when laying flat, these can be incredibly disabling. Now, in terms of can they go away, the answer is yes. Sometimes they do. But I would say that many times we are left with pain as a result of the damage that's done. And so there are many ways that we can address that, but I think the first step is bringing it up, making it known to your doctor and asking them, what's the right treatment for you and what can be done. And if one treatment doesn't work, don't give up. There are so many different options, and sometimes we have to combine different treatments to really get a good benefit.
Great, thank you. And yeah, we'll talk in a bit about the different ways of treating this neuropathic pain. How do you describe neuropathic pain and paresthesia, both sensation and kind of the severity of it, to someone who has no experience of it, considering it can be totally different from one person to the next? Dr. Boster?
Sure. I think that one way of trying to approach it is to just start talking about it. And I sometimes ask someone to describe it to me as if they were talking to their friend on the telephone. And don't get too caught up in using fancy words. Just talk about what it feels like, where it feels like it, the intensity level, what seems to make it get better and what seems to make it get worse. And that's a good place to start a conversation. We want the people on the call to know that it is normal, unfortunately, to experience this. It is caused by the underlying condition and it is treatable. So they're not making it up. It's quite real and it's terribly disabling. But as Dr. Nicholas has pointed out rather eloquently, it's treatable. And, we start that with a conversation where we dig in. Just to piggyback off something that Dr. Nicholas said, which I think is terribly important, the nervous system is super complex. It's arguably one of the most complex systems in the body. And it stands to reason that damage to the holiest of holies, the spinal cord and the brain, can result in not just one cause of neuropathic pain, but you might have several. So someone who has a transverse myelitis, for example, and their left leg is stiff and weak, they may have pain because they've changed the way they walk. And so they're beating up on their hip and their knee and their ankle joint, not on purpose. And they may have pain because they're not moving very much, and because they have stiffness of the muscles, and because there's dysesthesias or sensory changes. And we want to treat each one of those. And the way that we begin that process is by a very open conversation.
Great. Yep. Thank you. Yeah, we do get a lot of questions from our community kind of talking about these different types of pain and how best to, treat each of them depending on kind of the cause or what's going on. So moving on to medications, Just broadly, what medications are used to treat pain, and what's kind of used first, and then what are some other options that might be used a little bit later, depending, on the results. Dr. Nicholas?
Sure. So I think it's always important to understand, when we're selecting a medication, where the pain is, what the pain is like, what it feels like, and then determining, is this more of a nerve-related type pain, which may be more of the sort of burning sensation or painful sensation on the skin, versus spasticity, which we alluded to earlier, muscle stiffness, cramping, spasms, that type of pain, because we often find that different modalities work better for different symptoms. But again, the challenge is that there's been no excellent clinical trials to really determine, what is the algorithm of what to use first and then after that. And so a lot of times in the selection of choosing these treatments, what we're doing is we're trying to understand what are your symptoms as a whole. So for instance, if somebody comes in and they tell me, I have incredible burning pain on my legs, and they also tell me that they're feeling very depressed, I might think about the fact that when somebody has depression as well as burning dysesthesias, that there are actually many medications used to treat depression, which also have been approved for neuropathic pain or have shown significant benefit. And so one of those medications would be something like Cymbalta or duloxetine. And so we're always trying to not make your medication list as long as it could possibly be. We want to use, if we can use one medicine to kill two birds, we want to do that. And so I think that that's really important. Now, when we look at a sort of a broad range of what do we have available, probably the most common therapies that neurologists use to treat pain are actually anti-epileptics, so anti-seizure medications. One of the earliest anti-seizure medications used was something called gabapentin. And gabapentin is incredibly effective for neuropathic pain, but unfortunately it comes along with side effects like making you feel very sleepy or sometimes more confused, and even can cause leg swelling. But with this medicine, oftentimes, if it's started at a low dose and slowly titrated up, many people tolerate it very well, and it can work quite well to control pain. There's a newer version of that that's available that oftentimes if gabapentin isn't tolerated or is not as effective as we'd like it to be, oftentimes we use the newer medicine instead, and that's called pregabalin. Its brand name is Lyrica, and that's something that we also use quite frequently. These medications are dosed typically multiple times throughout the day, so that's another important thing, making sure that it's something somebody's going to be able to remember to take. But oftentimes people will tell me that their pain is maybe only at night when they're laying down to go to bed, and that's when it's the worst, and they really want that addressed. And so these medications can be dosed just based on the time of the day where somebody's experiencing the discomfort. Now, separate from that, we sometimes use other anti-epileptic medications off-label. So there are other anti-seizure medicines like lamotrigine or Tegretol. Tegretol's generic name is carbamazepine. Those we use in people oftentimes who have something called dystonic spasms. So sometimes if people have a severe damage in the spinal cord, they will experience these episodes where, one side of their body may cramp up and become really tight. And if somebody were watching them, it would almost look like a seizure, but they tell us that it's incredibly painful. And so one of the best medications to use for that is something called carbamazepine or Tegretol. And there's a newer medicine, not so new anymore, but newer than that one, called trileptal or oxcarbazepine. And so those are both medicines that we would use in that setting. And then we look at other classes of medicines. We are always trying to use something that is effective but also not expensive. We often use a class of medications called tricyclic antidepressants. And commonly used ones are amitriptyline or nortriptyline. And those medications actually can be quite effective. Those are, again, medications that are typically dosed once a day at bedtime. And again, when we start these medications, we typically have to start at a low dose, and we may need to increase over time. It usually takes about 4 to 6 weeks to really see the full benefit but in keeping in close communication with your neurologist, they can continue to titrate that up even without you coming back to the clinic. And then, as I mentioned, there are newer antidepressants which have shown benefit in neuropathic pain. So most of these are medications that are selective norepinephrine and serotonin reuptake inhibitors. And so Cymbalta or duloxetine is one of those. There are, several others that we can use. And then, finally, sometimes the medications that we commonly used aren't enough. And so we may employ other therapies outside of medications, and I think we're going to get to that shortly. But if somebody's not responding to neuropathic medications, then oftentimes we're collaborating with a pain specialist. So sometimes people will need narcotic medications for neuropathic pain. And then currently in the United States, many states have legalized the use of cannabis or medical marijuana for use of nerve-related pain and spasticity and in certain disease states. And so some people have found benefit from cannabinoids. When we talk about spasticity or muscle stiffness, because I really just addressed what we were talking about in terms of nerve-related pain, spasticity, that muscle tightness or stiffness, we use a lot of different treatments. So oftentimes, if somebody's coming in early, we want to use the least invasive means possible. So there are many muscle relaxers like Baclofen or Tizanidine are very common medications that we use. And those are simply to relax muscles and make them looser. Again, a challenge with those medications is they're incredibly sedating. And so sometimes, even though we believe that if we could get to a high enough dose that somebody could become loose enough, oftentimes somebody can't tolerate it and they become too sleepy. And so sleeping all day is really no way to live your life and enjoy your life. So sometimes Dr. Boster and I will use intrathecal baclofen, where actually people who have severe stiffness and pain related to that may have a device called a baclofen pump placed inside their abdomen that delivers liquid baclofen continuously to their spinal fluid. And then also for people who have stiffness that maybe is just in one arm or one limb, one leg, or just very few muscles, we do treatments such as botulinum toxin injection. So Botox injections can be incredibly beneficial. But as far as medical options, those are some of the most common.
Great, thank you. That was a really good overview. We will get into some more specific questions that we got from our community about each of those drugs or their experience with them. But before we get to that, Dr. Boster, do you mind just talking a little bit about? I know we talked about some of the side effects like fatigue. Are there any other side effects of these sort of pain medications, and how safe are they, Dr. Boster?
So I want to highlight three things that Dr. Nicholas said. The first one is, notice that she didn't start off talking about narcotics. And that's because narcotics are oftentimes not the best route to try to treat neuropathic pain. There are situations where we have to involve narcotics, but those are rare and far between. And I bring that up because I think a lot of very well-intended doctors with the very best of intentions see a human who's hurting and they give them a narcotic. The problem is that there's limiting returns and there's all kinds of side effects and complications that can arise from chronic narcotic use. And we try very diligently to completely and utterly avoid the class whenever possible, not because we don't want people to not hurt. On the contrary, we want to make them better. And we find that using chronic narcotics is really a slippery slope that ends up oftentimes worsening the pain syndrome. And so I wanted to highlight that. I also think that starting off with medicines like seizure medicines or depression medicines at first blush sounds weird. You say, I'm not depressed, I'm not having a seizure, why are you doing that? And this has largely to do with mechanistically the way these drugs work. A seizure is an electrical storm on the brain, and a seizure medicine prevents the electrical storm. It prevents an inappropriate electrical discharge. A lot of times, because of damage to the spinal cord or brain in the setting of a transverse myelitis or NMO or MS or what have you. We have these lesions, these areas of damage, which result in inappropriately firing neurons. And the neurons that are being fired create a pain signal. So it stands to reason that using an anti-seizure medicine to quell that inappropriate activation can really help someone. Similarly, when it comes down to the molecular level, the other way that the spinal cord communicates besides electricity is through chemicals, through neurotransmitters. And it turns out that some of the neurotransmitters which are modulated in antidepressants do amazingly good work at helping neuropathic pain. So I wanted to highlight that. Lastly, I just want to point out that one very powerful modality, and we can't highlight this enough, is physical therapy. So it's the rare person suffering from a spinal cord injury who has pain who doesn't benefit from targeted physical therapy. And in our minds, this is a critical part of the multi-pronged approach to making someone do better and hurt less. I bring it up because it sounds paradoxical. A patient will say, "Doc, you don't understand. If I move my leg, it kills me." And I say, "Yeah, I hear you. And if we continue to not move it, it's going to get worse and worse." And so I just wanted to point that out. Now, the specifics of the side effects, I think Dr. Nicholas did a fantastic job of reviewing some of those side effects. But I would say this to you. Everything is individualized in our field. And we're dealing with one family in front of us who has one set of issues, and we're trying our very best to negotiate the benefit of a drug against its side effect profile. Dr. Nicholas pointed out how we try to get twofers and threefers. So, for example, if you are having trouble with weight loss and you're having neuropathic pain, there's a medicine which tends to cause weight loss and treat pain. If you're a skinny mini and you can't put weight on, that would be a terrible drug to give you. If you're having a horrible time sleeping at night and you have neuropathic pain, we have a medicine that treats neuropathic pain, but it causes sedation. On the contrary, if you're sleeping all day long, that might not be the right one. So instead of answering your question with a litany of side effects, I would rather focus on the fact that every pill fits an ill, and we have to match the needs of the human being, the good, the bad, and the ugly, to what we're trying to pull off. And it's a discussion. It's an ongoing communication with the patient and the family to try to dial in the right approach. Unfortunately, we don't have a magical tricorder like on Star Trek where we can look ahead of time and say, oh, well, if we simply do X and Y, you won't hurt. And so instead, we're walking this journey with you, trying the best we can to figure out how to make it better.
Great, thank you. I think that's really important, especially because people are coming to these appointments with varying symptoms based on their transverse myelitis or neuromyelitis optica or one of the other conditions. So thank you for that summary. So just to jump into the kind of more specific questions, we got one question directly from our community that said, I've experienced side effects, increased bloating from higher doses of gabapentin. This was 900 milligrams of gabapentin. Would it be worth trying a different drug within the same class since the efficacy has been good? For example, trying something like Lyrica, or would I expect the same side effects? Dr. Nicholas?
Sure. So sorry to hear that you're having those side effects on gabapentin. It's definitely something that we can see. In terms of knowing if you would experience the same side effect on Lyrica, it's certainly possible, but we actually, it is a different medication. And so many times when I have somebody who has had good benefit in terms of their neuropathic pain on gabapentin and they have a side effect like that, I have found that switching to Lyrica has worked many times. And so I think that's a completely excellent choice to consider and to try. And I think if that, it's not that hard to do. And if you benefit on a Lyrica and didn't have that side effect, that would be wonderful. But of course, if you went on Lyrica and you had the same side effect, you could pretty quickly be tried on an alternative therapy. As we mentioned, there are so many other options out there. So, if Lyrica didn't work, I'm sure that there, are many other medications that you could try that may not cause the same side effect.
And if I can piggyback off you for just a quick second, there's another approach before you leave Neurontin. Sometimes we see patients in clinic and we may bring up, for example, starting a gabapentin and Neurontin and say, oh my gosh, doc, I can't do that. I had the worst experience. And when we ask them, well, how was it started? They said, yeah, well, the doc started me on 600 milligrams 4 times a day and I was a zombie. And this has to do with how we titrate the medicine. So sometimes before we completely bail on a medicine, we might take 3 steps back and start with Neurontin maybe 100 once a day and keep them on that until they're comfortable, and then slowly go to 100 twice a day. And then over a couple of weeks, go to 103 times a day. And by slowly and incrementally increasing the dose, sometimes we can mitigate those annoying side effects as the person gets used to the medicine, and we can still have the benefit. So I just want to point out that if the first exposure to a medicine is met with unnecessary side effects, there are sometimes ways to navigate around that.
Great, thank you. We got another question about Lyrica. So this person takes 600 milligrams of Lyrica per day for nerve pain, and it only subdues the pain in their hands and throughout their body by about 80%. Is there anything else recommended that would maybe alleviate all of the pain more effectively than just that sort of 80%? Dr. Boster?
So this speaks to the need for multiple modalities. It's a fool that is going to take care of a symptom with one pill only. Now, sometimes we're lucky and that works, but oftentimes that doesn't work. And I think what we need to do as clinicians is we need to look at the whole picture. And I would hope that this person is involved in aquatic therapy. I would hope that they're involved in occupational and physical therapy. I would hope that they're doing a stretching regimen. And in addition to their Lyrica, we may need to add a second, third, fourth, or fifth medicine so that we can totally control that discomfort. There's lots of different tricks and tips, and I never feel like we're going to knock it out of the park with one drug alone. I think that we have to be very broad in our thinking, and I'll give you an example. Maybe if the Lyrica is knocking down most of the pain, a topical numbing cream might take care of the other portion. So I wouldn't view it as a binary all or none. I would certainly view it as a spectrum and try to bring on different modalities as tolerated for the goal in mind.
Thank you. And then we got another question that this person has numbness and tingling in their hands and feet. Are there any different medications to treat this, or would this be something that pain medication would be used for? Dr. Nicholas?
So numbness and tingling in the hands and feet can be incredibly uncomfortable and painful. And certainly if this has occurred as a result of problems within the spinal cord, brain, or peripheral nerves, we often would try our neuropathic pain medications to decrease the intensity of the discomfort. The challenge is that really no matter what we use, we can't give you back normal sensation. The only thing that really may help with that is time, because we do have some repair after an initial attack. Typically we would see improvement for up to a year, but that's not an absolute limit. But if that numbness and tingling is annoying, oftentimes using these neuropathic pain medications like gabapentin or Lyrica, or even amitriptyline or nortriptyline can be incredibly helpful. Many people say that being on those medications makes it more tolerable, although again, it does not give back normal sensation.
Great, thank you. And we get questions actually about this topic fairly frequently, where someone has an attack. For example, this person had an attack that was 5 or more years ago, but their symptoms have been flaring up more than usual recently. Does this indicate that more permanent damage is taking place, or what might be happening in terms of what might be going on to cause this kind of increase in symptoms? They're currently not receiving any treatment. Dr. Boster?
So this is an excellent point that you bring up. And I think that we have to reflect that a human being isn't a textbook. And they don't have an answer. They have a symptom. They experience something. So in this example, you're talking about someone who's experiencing a worsening of baseline pain. They could have a worsening of baseline pain because of an undiagnosed urinary tract infection or decubitus ulcer. They could have a worsening of pain because their tendons have shortened and it's hurting their joints as they move. They could have a worsening of pain because of an underlying cardiovascular problem or a diabetic problem completely unrelated to this injury. Or depending on the type of damage, whether, let's say that they have a spinal cord syndrome that can recur, like neuromyelitis optica, they could be having new inflammatory damage. The take-home point here is that human being just experiences ow, and we have to work as partners to be detectives to figure out what's causing the worsening of the pain. It would be inappropriate to simply, quote, throw medicines, end quote, at them. Instead, we might need to do some testing. We might need to look more broadly and check their urine and get chest x-rays and CT scans and MRIs and EMGs as we try to uncover what's going on. The reason I bring that up is that will drive how we treat the discomfort. If we identify, oh my goodness gracious, you had a transverse myelitis 5 years ago, you have undiagnosed diabetes and you have neuropathy in your nerves, we're going to obviously continue to treat the neuropathic pain, but we're also going to need to treat the diabetes.
Got it. That makes sense. Thank you. And we did get a question live during this podcast about lidocaine infusions. Do either of you have any experience with this, or is this in the research phase, or is it being used in practice?
So I can speak to that. So currently, that's not something that I've seen in our practice where we are. This is something that I have seen used for people with complex regional pain syndrome. So that's a condition where someone has some type of injury to a limb, and then they have abnormal sensory input to that limb and often incredibly severe pain. And there are many studies showing that lidocaine infusions can be quite beneficial in that setting. So I think that is something that is used, but I would say that it's incredibly rare. But in certain rare cases, that would be something that certainly could be considered.
Got it. Thank you.
Something that's a bit less uncommon and done a bit more commonly as it relates to lidocaine are topical applications of lidocaine. So we will sometimes ask compounding pharmacies to create creams that contain lidocaine, or you can purchase patches that are impregnated with lidocaine and apply them against the skin. And this can be a nice adjunctive therapy to ongoing therapies to help with a focal area.
Thank you for that. And I know earlier both the medications Baclofen and tizanidine have been mentioned, but we did get a question asking if both of those can be used at the same time. Dr. Boster?
The answer is yes. Baclofen works by stimulating a receptor called the GABA-B receptor. And Zanaflex or tizanidine works through a completely different mechanism, an alpha-adrenergic mechanism. And so they're both pills, but what they do in the body is rather different. And because of that, we could use them together. Now, there are side effects from both, the most common one being sedation. And so sometimes when we add them together, there's an additive side effect profile where people get particularly tired. Some of the ways that we address that would be, for example, using Baclofen breakfast, lunch, dinner, and before bed, and adding tizanidine or Zanaflex along with the evening Baclofen before bed. So if there's a cumulative sedative effect, it occurs during night time, and then you can go to sleep. But the short answer is you can combine them, and we oftentimes do.
Okay, thank you. And then, Dr. Nicholas, you did talk a little bit about the use of cannabis or medical marijuana in certain states. And I know in different states they have kind of CBD heavy ones versus THC heavy ones, and have either of those been shown to provide relief in terms of neuropathic pain, or does it vary based on the person?
So certainly this has been something that's been moved forward politically, I think by many people who have found benefit on their own, which I think is exciting. I think one of the challenges that we have as physicians is that we're very used to drugs when they're introduced or found in research. They go through rigorous clinical trials so that we can thoroughly study them and better understand what their side effects are and what the risks are and what the true benefits are. I will tell you that, many patients that I see have used CBD oil, which is something that they can purchase freely online or in stores, even without a medical marijuana card. But one of the challenges is with that not being regulated, we really don't know what they're getting or what the true composition of that treatment is. I have many patients who have felt that this helped significantly, where they were able to actually come off their neuropathic pain medications. And then I've had just as many patients tell me that they tried it and they didn't notice anything. In my opinion, I think that we need a lot more studies. And fortunately, some of those studies are starting to occur. There certainly have been studies of CBD-based medications in looking at treating conditions like epilepsy. We don't have results yet of full clinical trials showing that, again, in randomized clinical trials in MS or transverse myelitis or neuromyelitis optica, but I think it's only a matter of time. One of the things that our concern is that obviously, although CBD is very interesting and may truly benefit neuropathic pain and spasticity, we certainly worry about the THC component and that component being damaging to the neurons within the central nervous system. And so oftentimes when somebody has one of these diseases, it does not, it is an increased risk for damage to the brain and shrinkage and atrophy. And so we want to be really careful about what we know and what we don't know. There is a neurotherapy that's being studied in clinical trials called nabiximols, which I think is exciting and may give us a bit more information. And then certainly, as I mentioned, there's already a therapy called Epidiolex, which is being used in epilepsy, which has been shown to reduce seizures. So I think down the road, a few years from now, we'll have a lot more information. Currently, I do have patients who are using that who, again, have found benefit, but it's very hard for us to predict who will benefit and who won't and what the potential risks may be of using an unregulated supplement for purchase.
Great, thank you. And just moving on away from kind of these medications, we did get some questions about non-medication pain relief techniques. So are there any non-medication techniques for treating numbness and tingling and neuropathic pain? Dr. Boster?
Heck yeah, there are. There's a whole bunch. So probably something which is underappreciated in Western culture is the value of meditation and mindfulness. And before you roll your eyes on the phone, I challenge you to try it. Many patients using biofeedback or meditation or mindfulness techniques are able to dampen their pain. And this is genuinely completely unappreciated with the Western medical model. And yet, when we're trying to help someone, we want to do whatever is possible. And so I think that that's a modality which is underappreciated. As I mentioned earlier, there's innumerate types of physical therapies which have been shown to decrease pain. One of my faves is aquatic therapy. It can be remarkable in its ability to decrease pain. In other cultures, things like acupuncture are standard of care, like in China. Here in the United States, acupuncture is considered by many allopathic doctors to be complementary. And yet I have patients that have found some relief anecdotally when they go to an expert acupuncturist. Medical massage can be very, very valuable in helping with various types of musculoskeletal and neuropathic pain, and particularly in the world of spasticity can be very helpful. There's also options of medicine by Edison. And so people that have neuropathic pain from spinal cord damage sometimes have life-changing benefit from spinal cord stimulators. A spinal cord stimulator, simply explained, they put these very, very thin wires on either side of your spine, and they run electricity across them. And they quite literally use the electricity to cancel out the pain signals. And so this is a non-medicine option, which can be life-changing in some cases. I could go on for another 10 minutes, but the take-home really is that we have to have a broad mind and think beyond exclusively a pill if we're trying to win.
Thanks. Thank you. And so I know you mentioned the epidural, the stimulators, spinal stimulators. Have you heard anything about scrambler therapy or the use of electrical stimulation in general? One person said that they have found that it has helped their neuropathic pain. Dr. Nicholas?
Sure. So scrambler therapy is an idea that that was discovered quite some time ago, and thought that if you can use electrical stimulation to the skin, that you may be able to stimulate other neuropathic pathways and sort of confuse the pain signals so that somebody's not experiencing the same pain, or the areas that they have previously felt are painful are not painful anymore. And so there actually have been many studies on this looking at cancer-related pain. And currently, Dr. Michael Levy at Johns Hopkins, who's a world-renowned expert in NMO, is actually running a clinical trial in neuromyelitis optica, which I think is really exciting. And so this is something that has been around for quite some time, and I think certainly may be of benefit in folks with transverse myelitis, MS, or NMO. One of the things that I just wanted to add to that, I think that was a nice, very comprehensive list that Dr. Boster mentioned of non-medication therapies. He mentioned biofeedback, acupuncture, massage, meditation. In addition to that, again, as much as you may roll your eyes on this topic, there have been a number of studies in demyelinating diseases showing that exercise actually can help neuropathic pain. And so this is something that definitely we discuss day in and day out, and our neurophysical therapists actually run wellness programs to help people become involved and develop a healthy lifestyle of becoming more active. And one of the challenges is when you have pain or you have spasticity-related pain, you really want to isolate yourself, and you think, oh my goodness, if I go out and move, this is going to get worse. But fortunately, the studies actually show the opposite. And so making sure that you aren't becoming sedentary, and maybe that's something where you need to talk with your doc and get in for some physical therapy, and then get a regular exercise program that can be incredibly helpful in combination with medication and some of these other options. The other thing is that there are certainly newer therapies. So I know we've talked about acupuncture, this ancient Chinese art for treating pain, for quite some time. Some people that I care for are even doing therapy like cupping, where they go to a expert in this and actually have warm or hot cups placed over the skin or the area of pain, and this suction is thought to help to relieve some of that discomfort. And it sounds crazy, but I have many patients who have found significant benefit with that. And then I think finally, the basics, right? So we have to make sure that we are helping you to meet the basics of life that are important. A lot of us forget that sleep is important. If we're not sleeping well, or we're not getting sleep, all of our chronic symptoms related to our neurologic disease are going to be worse. We have to make sure that you're eating right. If you're eating fast food all the time and processed food, unfortunately, it feels good at the time we eat it. I like it too, but if you eat that, you will not feel so good afterwards. And oftentimes that can increase the symptoms. We know that smoking actually, not only is that worse for your disease, but it also can increase your pain. There are several studies showing this. And then finally, making sure that we're managing depression and anxiety, which are very common in America to begin with, but also incredibly common when you've been affected by a neurologic disease. And so psychological therapy can also benefit, and has been demonstrated to benefit neuropathic pain.
Great, thank you. That was a good overview as well. And And then we got a question about diets that are designed to control inflammation and decrease pain, such as the Walls protocol. Dr. Boster, do you have any experience or information about that?
Sure. So I think that we have to differentiate the concept of anecdotal results from scientific evidence. So let's do that very briefly. If somebody tries something and it works for them, that's awesome. That's like a really great thing. But because somebody tried something and it worked for them doesn't make it scientifically valid. And I'll use the Walls diet as an example in the setting of MS. There are claims that by avoiding certain foods and eating exorbitant amounts of others, that you can, quote, cure the disease, which is a fallacy. That's completely false. And if this worked for an individual, God bless her. I think that's absolutely fantastic. But I think that we have to be very careful in propagating concepts of false hope. It is true that by eating certain foods, we can create a more or a less inflammatory milieu in the body. And anecdotally, I have patients that have adopted various diets, for example, a vegetarian diet or, for example, a paleo diet, and they will experience a decrease in their symptoms. They'll experience less fatigue sometimes. Sometimes they'll experience less pain. And so, whereas there to date is no proven diet that results in a decrement of neuropathic pain, there's no proven diet that slows a neuroimmunologic condition. If avoiding certain foods makes you feel better, that's fantastic. And again, I think that we have to be aware of the differences between an anecdotal benefit and a scientific reality.
Great, thank you. And then kind of moving away from these non-medication ways to manage pain, we've had a few questions that are related to pain that maybe comes and goes or is based on certain situations. So one of the questions is, why does neuropathic pain and paresthesia increase if you're having a pseudo relapse if there's no new demyelination? Dr. Nicholas?
Sure. So that's a great question and a really common question that I have in the clinic. So when somebody's having a pseudo relapse, that's obviously defined as somebody feeling an increase in chronic symptoms or maybe symptoms that they had with their initial attack of transverse myelitis or MS or NMO. And that commonly occurs when the body temperature is elevated for some reason. It doesn't have to mean that you check your temperature and you have a fever, but even your normal baseline body temperature being slightly elevated actually results in a slowing of the signals traveling along the neurons in your brain and your spinal cord. And so if you have some type of damage from your prior neurologic event and your body temperature is raised by something like the hot weather outside that we seem to not have here in Ohio because it's raining all the time and cool, even though it's June. But in the coming months, I expect that our temperatures will rise if somebody's outside and becomes overheated, or they have an infection like a urinary tract infection, or they're just really stressed because life is incredibly stressful at times. That can raise that core body temperature. And when that's raised, those signals don't travel as smoothly along the neurons. And when that occurs, those old symptoms can come out and seem worse. And so many times somebody who maybe has had a burning pain or an intense numbness or an itchiness of their skin caused by this damage resulting in neuropathic pain, it can fluctuate based on this because any noxious, which means annoying stimulus to the body, can increase it. And so as best as we can, we have to keep that in check. So if you're noticing that you have an increase and you say, hey, wait a minute, this was under great control, what's happening? Maybe that's the time where you want to check in with yourself and say, what's going on? Am I stressed right now? Is there something happening in my life that can explain this? And if not, then maybe you want to talk with your doc and see, do I have a urinary tract infection? Is there something else going on that can explain this? Because just piling on more and more symptomatic medications may not be the answer. It may be that there's something that's increasing this discomfort. And so again, it's a very, very common symptom, but it's a well-described phenomenon.
Great, thank you. And then we got another question that says, on occasion, I've experienced elevated nerve pain beyond its normal level. Is the increase in nerve pain a negative, and does it mean we've taxed the nervous system, or is it a positive, and does it mean that the generation of new nerves is occurring? Dr. Boster?
So with the information provided, we simply can't give an answer beyond saying, yes, it's possible. We need to know more information to be able to sort that out. To piggyback off something Dr. Nicholas said, when people experience a reemergent symptom, it can be very discombobulating and confusing. And I'll provide a quick analogy. Imagine that some Yahoo drives their Ford Buick through your living room wall. And so there's a hole in your living room. And, the police come and they haul the car away and they clean up the mess, but they don't repair the hole. And so a week later, as you're sitting in your living room and it starts raining outside, you get wet. And every time it rains, you get wet. Well, the damage to the wall occurred weeks ago, but it's still there. And so as conditions fluctuate, you experience them. And when you have damage to your spinal cord and it functionally improves, it doesn't mean that the spinal cord damage is gone. Oftentimes what it means is your body's figured out a workaround. And if you stress or tax the body, as Dr. Nicholas described, with a urinary tract infection or being overheated, sometimes those workarounds fail you. And the human experience is a reemergence of those symptoms in the same way that if it starts raining outside again, you're going to get wet in your living room.
Got it. Thank you. And as we're getting to the end of the time for this podcast, I just wanted to open it up to both of you to kind of mention anything you think is important that we haven't talked about today, or anything moving forward. Dr. Nicholas, do you want to start?
Sure. I think the bottom line is to understand that if you're having neuropathic pain, that it's important to get help. And if you're going to a neurologist, please bring it up. Make it a priority in your visit, because this is an incredibly important symptom to treat to improve your quality of life. And I'm positive that there is something that we can do for every person, even people who have tried what they believe to be every treatment imaginable. There are many options. And as was mentioned earlier, oftentimes it's a combination of options, whether that be medications or non-medical therapies, that can result in the best benefit. So please know that help is out there, and there are some excellent neurologists across the country who treat these diseases who can help you to manage your pain. So I wish all of you the best, and thank you so much for listening tonight.
Thank you. And Dr. Boster, do you have anything to add?
Just that so much of damage to the spinal cord, whether that be transverse myelitis, neuromyelitis optica, multiple sclerosis, or some other condition, so much of it is invisible. So neuropathic pain is an invisible symptom. How oftentimes are you told, but honey, you look so good? Because the casual outside observer can't see what's going on. And I want to highlight that even though it's invisible to the outside observer, it's still real. And just because they can't see it doesn't diminish the experience. And I want to empower you to feel confident that, yes, this is very, very real. And yes, it's very debilitating. And yes, people like Dr. Nicholas and myself and folks at OhioHealth and around the country would love to help you. Thank you again for listening, and thank you for giving up part of your evening to talk with us, to up your game as it relates to improving neuropathic pain.
Thank you. Thank you both so much for taking the time today. I know we got through a lot of questions. We really appreciate it, and our community appreciates it as well. So thank you both so much.
Take care.
Thank you.